Now let's take a look at nursing care for these patients. So we're going to monitor vital signs, especially for signs and symptoms of alcohol withdrawal, which would be an increased blood pressure, increased heart rate, and increased temperature. Monitor the client's fluid volume excess. You want to get daily weights every morning at the same time. Also assess abdominal girth and measure at the umbilicus. Have the patient on strict INOs, and also check the patient's peripheral edema and restrict sodium and fluids as ordered. Provide comfort for the patient by positioning them with the head of the bed up and having their feet elevated. This will help with their respiratory effort. Monitor their oxygen saturation levels and for any signs of respiratory distress. Poor nutrition leads to impaired skin integrity. Implement measures to prevent pressure ulcers. Remember that pruritus caused from the bowel salt accumulation will make the patients itch, and that can create sores on the patient. Encourage the client to shower in cold water and apply lotion to dry skin. It's very important to monitor the patient for changes in mental status. We're going to be looking for signs of hepatic encephalopathy. So astextrus is the flappy hand tremor, hepaticus, the fruity breath, death breath odor, and we'll just be noticing if they have any changes with confusion or memory loss or anything that has to do with their mental status. Remember to help the client with their high calorie, high carbohydrate, high protein, moderate fat, and low sodium diet with their vitamin supplements such as folate for the folic acid and the multivitamins and B vitamins. But also remember that these clients have anorexia, so they don't want to eat very often. So try to do frequent small meals throughout the day and then provide things like Boost or Ensure to help get those calorie needs in. Remember, in the presence of hepatic encephalopathy, when the ammonia levels are rising, we need to switch their diet from a high protein to a low protein diet. Now, we definitely need to watch out for signs and symptoms of bleeding. And the first ones we want to be careful about is GI bleeding. So we want to teach the patient to look for signs of blood in their stool called melena, or vomiting blood, hematemesis. And these are not good. These are signs of esophageal varices that have burst, or perhaps their blood is so thin that they're having a lower GI bleed from other things, or it could be a bleeding ulcer if they have alcoholism that causes ulcers in the stomach. So any sort of GI bleeding is not a good thing and needs to be seen as immediately. And then there's the just signs of bleeding on the skin that are apparent, so increased purpura or epistaxis, and those would indicate that their platelets may be low, so maybe they need to be evaluated for a transfusion or something. Give the patient emotional support. This is not a pain-free disease either, so they will need to have their pain medication as needed, so take care of that for them. And also provide diet teaching, whatever they need to understand the importance of their diet. Now let's look at what we must teach for the nurse. Remind the patient no NSAIDs. NSAIDs increase bleeding times and they're caustic to the stomach lining. They can create ulcers. So we want to teach no NSAIDs. So that's no aspirin, no Motrin, no Advil, no ibuprofen, those things. Teach bleeding precautions. So just like a patient who is on Coumadin, these patients already have low blood levels, so we want to teach them bleeding precautions. So don't use razors, use the electric clippers, use soft toothbrushes, those kind of things. Proper nutrition, we need to teach them how to have enough calories throughout the day. Alternate rest with activity. Elevate their legs to help return some of that dependent edema back to the heart. And then teach them no alcohol. Although no alcohol is sometimes not appropriate for patients, we can tell them to limit or decrease the amount of alcohol that they're using, but we can't tell them to stop cold turkey. Now let's look at an overview of everything we have discussed about liver cirrhosis. Let's take a look at our signs and symptoms. We have our early symptoms, and these are very vague symptoms, and some of these late symptoms can also be included in the early symptoms, but it just depends on how far advanced their cirrhosis has become. So we do begin with an intermittent fever. They have some stomach upset, indigestion. They have the spider angiomas, or little firecracker spider-looking veins that they have showing up. It does have a distinct center, and it branches out from it. Palmar erythema, red palms, and gynecomastia is enlarged male breast. And all three of these things here have to do with an increase in estrogen levels. So estrogen is a hormone that filters through the liver and metabolizes. So if we can't send that hormone through the liver and have it go where it needs to go, it kind of accumulates in the body, and this is how it manifests itself. Right upper quadrant pain is very common. Epistaxis, nosebleeds, so signs of bleeding. May have some easy bruising at this time also, some purpura, petechiae. Dependent edema and anorexia, so they're having some inability to have an appetite, so they may have some weight loss as well. And we see that over here, anorexia leads to weight loss. So they become, as the disease advances, they become very thin appendages, thin arms, thin legs, and an enlarged abdomen. They'll begin to have a constant mild fever at this point. We have 4 things that indicate that the patient is in full cirrhosis of the liver, and decompensated means the body's not trying to fix it anymore, that it's too late. They have a severe cirrhosis now. So that's ascites, so starting to build up fluid in the abdomen. Jaundice, yellowing of the skin. They've developed portal hypertension, and then esophageal varices. So these 4 things are indications of a late and decompensated, that's an absolute. The others, mild fever, weight loss, muscle atrophy, itching, pruritus. You'll usually see the pruritus when they actually have jaundice. So pruritus may stick over here in the late, but they can have some beginning pruritus over here. Tremors is going to be related to your acid dexterous, so maybe some increased ammonia levels. White nails and clubbing, clay stools, the inability to remove bilirubin from the blood and not making enough bile. So here we have the bile is what turns our stool brown. So we're going to have clay color stools because we're not getting this in our stool. We're not breaking down fat, so they have very fatty stools. Sometimes it's called white stool, clay stool, but the correct term is steatorrhea. You may see it listed either way. Tea-colored urine for the same reason. It may also be labeled as dark urine. So we just have our symptoms. So these 4, jaundice, esophageal varices, portal hypertension, and ascites are all definite late. The rest of them can waver into early, but don't think too hard of that. Just remember these 4 here. Now the portal hypertension, leads to the esophageal varices and ascites as well. And remember, ascites can convert over into pleural effusion, and these things will create shortness of breath for the patient. We could treat the portal hypertension with the TIPS shunt procedure, given atenolol beta blockers. Propranolol is the other name for that drug, and a low sodium diet. When the disease advances, now you could go back and forth from severe to back over here, severe to back over here. So you could kind of treat this if you could control the ammonia levels. So severe hepatic encephalopathy is from high ammonia levels, and we know that is happening when the patient starts to exhibit memory loss changes. So when they start to have memory loss and changes in mental status, we can pretty much guarantee their ammonia levels are high, and then we need to start doing other things like decreasing their protein in their diet at this point. Acid dexterous, remember, it's the flappy hand tremors. If we do not treat this, the high ammonia levels will cause comatose and death. So we need to give antibiotics, which helps decrease the gut bacteria. The antibiotics of choice are the mycins. It's like neomycin and kantomycin or Cantrex. And lactulose will help decrease the ammonia level via diarrhea. So it'll give the patient diarrhea, which helps relieve some of the ammonia levels in the gut, which helps relieve it in the blood. So when we look at signs and symptoms, we also got to remember our labs are considered signs and symptoms as well as even consider some of the diagnostic tests. So we have increased liver enzymes, or ALP, AST, and ALT, increased bilirubin, increased lactic acid, or LDH, our increased clotting times, our PT and INR will be up. So normal INR is less than 2, so maybe their INR will be 3, 4, right around there, I suppose. Increased ammonia levels, that's really going to be indicative of severe hepatic encephalopathy here. They will have low protein and low albumin. They are anemic, so they have low iron and they have low hemoglobin, and we have low protein because we don't have enough hemoglobin, and we have low albumin, poor nutrition, and that our liver's just not making it. Low sodium, but it's a fake low sodium. We're still going to tell them a low sodium diet is a low sodium fake because it's a fluid dilution. So it's diluted in a lot of fluid. So when they pull the lab work off, it just looks like there's not very much in there. But if they had a normal fluid level, it would be too high. Low hemoglobin, hematocrit, low platelets. So that's going to give us a bleeding risk. It'll give us fatigue, not having enough hemoglobin, and low white blood cells because of splenomegaly. Now, we need to diagnose liver cirrhosis. That'll be done through a liver biopsy. An EGD with varices is very common. Then they'll biopsy the liver to confirm. We could look at their lab work too and assume that they have it. When we go over here to our medications, aldactone or spironolactone is the other name for this drug. Potassium-sparing diuretic. We need to get all this ascites fluid off. So, because if we don't treat this fluid here, pleural effusion and then ascites, it leads to shortness of breath. It's also going to put a lot of pressure on the kidneys. It could cause kidney failure. So we have to watch our kidney function tests as well, your creatinine level. But if we don't treat this, it's going to cause heart failure as well. So we have to get all this fluid off. Aldactone, so potassium-sparing diuretic. Lactulose, it decreases the ammonia. Antibiotics, we talked about that. The mycins are preferred. Atenolol, propranolol, decreases the portal hypertension. We need something to help break down the fat or help the fat to be small enough for absorption, and that would be the urodeoxycholic acid and the urosodiol. Nclex-rn or cholestyramine is for itching from the bile salt accumulation. IV albumin is given to pull the edema into the ascites and into the from the ascites and into the vessels, and then we can get a diuretic to help get rid of some of the fluid we're pulling back into the vessels. So these two kind of go together. Platelet transfusion if needed. Vitamin replacements. Remember, we are not, come up here, we're not absorbing these vitamins and minerals right here, so we need to replace those. Riboflavin are B vitamins. Folate is your folic acid. Vitamin K may be indicated if they need help with clotting. For nursing care, we'll look at our diet plan. Small frequent meals, high protein, high calorie. We'll also give them like Boost and Ensure, things like that. Moderate fat, low sodium, because we already have fluid retention. Vitamin replacements. But if they develop encephalopathy, make sure, and we will know that when they have increased ammonia. So how do we know they have increased ammonia? We go down here and we see that they start having changes in their orientation or mental status, memory loss. Start acting goofy, horrible, fruity, odored breath, and maybe some tremors here. Okay, so if we start seeing those symptoms, we'll indicate a need to decrease the protein in the diet at that point. So it'll change from high to low. We have fat malabsorption. and that'll be indicated by steatorrhea, the white clay stools, and then the T urine, really dark urine. Anorexia leads to weight loss, decreased absorption of fat-soluble vitamins because we're not absorbing fat either. So we can't absorb the vitamins if we can't break down the fat small enough for this. So those deficiencies are there. High blood sugars with bouts of low. Fluid volume excess is manifested by ascites, dependent edema. So we need to check their legs for edema. Hyponatremia because it's diluted. Nursing care. Here's what the nurse is going to do. We're going to manage this fluid volume excess by getting daily weights every day in the morning. Strict diagnose, measure the abdominal girth. We're going to watch your vital signs for signs of alcohol withdrawal. Keep their head of the bed up because they have a large abdomen, ascites, hard to breathe, pushing on the diaphragm. Check their O2 stats to make sure we're not having any pleural effusions that are also affecting their way they're breathing. Their nutrition is horrible, so their skincare needs to be dealt with. The itching could create sores, and we need to make sure we take care of their skin. Watch for changes in the mental status, because this means that we're going to get into worse stages here that could lead to death. I want to prevent those complications. Watch for signs and symptoms of bleeding. So hematemesis, melena, increased bruising, bleeding, nosebleeds. Teach the patient no NSAIDs or things that increase bleeding times, like kava, herbal stuff that they should not be taking. Bleeding precautions, so things they don't want to accidentally cut themselves, or they might need a soft toothbrush or don't have bleeding gums. Teach them about their diet and low sodium diet, alternate rest with activity. Have them elevate their legs when they're at rest to help pull some of that dependent edema up. Limit their alcohol intake. We need to teach them to try and stop drinking alcohol, give them the resources to get on that right path. And remember, they have right upper quadrant pain, so we'll need to deal with their pain. But, Tylenol is not a good medication because it hurts the liver. So we would just go whatever the physician orders for pain medications and then provide them emotional support. So I hope that this overview helps put it all together for you. And thank you for listening to the Liver Cirrhosis lecture.